Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers, where we explore the science, strategies, and stories shaping modern rheumatology care. I'm your host, Amanda Mixon, the current president of RhAPP. In this episode, we're going to take a closer look at something that's increasingly relevant to rheumatology providers, the intersection between joint and gut inflammation. With overlapping immune pathways, shared mechanisms of action, and I'll just do that one sentence over. With overlapping immune pathways, shared mechanisms of action, and emerging subcutaneous biologic options, the management of IBD offers valuable insights for our patients with conditions like psoriatic arthritis, axial spondyloarthritis, and other IMIDs. To help connect the dots, I am joined by Christina Hanson, a member of the GAP Board of Trustees and an expert in her field. Christina, to our listeners who might be unfamiliar with you, would you mind giving us a brief introduction?
Absolutely. And first and foremost, I just wanted to thank you for having me on today, this special RhAPPcast episode. And I love the title, SubQ Solutions. So yes, I'm a nurse practitioner. I've been practicing at South Denver GI here in Colorado for nearly 20 years. It is a community-based private practice. We do have a research department at SDGI, which I've had the privilege of being a sub-investigator in over the years. And as you mentioned, Amanda, I am a course director and board of trustee for GAP, which, like RhAPP, is an educational organization for APPs in the GI and hepatology space with a goal of educating, elevating, and empowering APPs.
Well, I know personally, I'm so, honored to have you on. We share patience, which is so incredible, and why it's just it's so meaningful to have these relationships with cross specialty, because again, when you're able to pick up the phone and say, hey, I have this patient and I'm not exactly sure what's going on, can you see them? Obviously, so much better patient care happens. I have a better understanding of what's going on, and it's just all over a much, much better situation for everyone.
Absolutely.
Thank you so much again for being here. I think it's going to be just such an amazing episode for our listeners. Together, we're going to explore how advances in subcutaneous biologic therapy are shaping induction and maintenance strategies, improving patient convenience, and redefining collaborative care between rheumatology and gastroenterology. So let's just dive right in. This is RhAPPcast. So I'm going to ask you a series of questions, Christina, since you are definitely an expert in the field. So we've seen this growing shift towards subcutaneous biologic options, which is so awesome for our patients. They really don't want to be coming in all the time for infusions, etc. So from your perspective, what are the main clinical and logistical advantages that these bring to both patients and providers?
Yeah, well, Amanda, you're absolutely right. And I would say certainly for our patients, the SubQ treatment option in the space of IBD, and I'm sure you're seeing in rheumatology as well, has certainly brought about an improvement of their quality of life and convenience for them. Patients often tend to prefer this ability for this self-administration at home, eliminating that need for travel to a hospital or infusion center, which obviously clearly greatly reduces time commitment. I mean, you and I are out here in Colorado. We, for those of you that might not know, Amanda and I both practice in Colorado in separate cities, but we get a lot of patients that are in the mountains or in remote areas of Colorado. And certainly it can be a time commitment to come down out of the mountains to the infusion centers, or difficult to get those in-home infusions based on their location. So we recognize that the use of injections take mere minutes to administer compared to the hour or several hours that's required for those IV infusions. And our patients aren't having to be tied up to that chair and leash as they're required with these infusions. I think SubQ injection administration can come with a better safety profile as well, with low risk of systemic infection, as generally infections with SubQ are limited to that injection site if they occur at all. And certainly fewer systemic infusion-related reactions that can occur. We can see flu-like symptoms, nausea, fatigue, etc. And in some sense, SubQ options might provide more consistent drug levels with slower, more sustained absorption, leading to potentially more stable drug levels in the bloodstream, which again may reduce certain side effects. And then from really a provider standpoint or their healthcare system, we recognize that this convenience and ease of use for our patients with self-administered SubQ injections often leads to better patient adherence to their long-term treatment plan. Logistically, SubQ options clearly have a more simplified distribution compared to IV therapies. And the shift to this self-administration really reduces the strain on our clinical and hospital systems, which can free up valuable time in the chair and clinical staff time for other needs. And I think many of the SubQ treatments utilize a fixed dosing regimen, which eliminates that need for us to have to calculate these complex doses based on body weight, reducing that potential for dosing errors. So clearly there's an overall benefit, cost savings considerations, safety, and probably most of all, convenience from moving from that infusion to that home self-administration with SubQ treatment options.
How do induction and maintenance strategies differ when you're using subcutaneous formulations for Crohn's and ulcerative colitis?
Yeah. So, and as you've been experiencing again in the rheumatology space as well, for us in GI and in the space, particularly in inflammatory bowel disease, we've been fortunate to be inundated with multiple new therapies over the past several years, really with great efficacy and fantastic safety profiles. And we almost don't know what to do with them all. I don't know if you're experiencing the same thing, but this isn't a bad problem to have. And in addition to these great therapies, we can further offer our patients that flexibility with the option of SubQ administration, and mainly for maintenance following that IV induction. But we do have one IL-23 therapy agent that has SubQ availability as both induction and maintenance, which obviously is fantastic to be able to offer to our patients. And again, with, spectacular efficacy. And then to answer the questions, when it comes to considerations or differences around induction versus maintenance, induction strategies for Crohn's and ulcerative colitis using SubQ formulations primarily rely on higher, more frequent dosing to quickly achieve that remission. And some of the therapies, as I mentioned, still do require that initial IV loading dose before transitioning over to the SubQ maintenance. In contrast, maintenance strategies involve lower, less frequent dosing to sustain the remission achieved during induction. There is some data that suggests the efficacy of SubQ administration in Crohn's disease has shown a similar efficacy to IV for inducing remission, and may even be better for maintenance of remission for some of the IL-12/23 inhibitors. And then for UC, for ulcerative colitis, SubQ administration is generally effective for maintenance, but there are some studies, some data that indicate lower efficacy for at least that initial induction of remission compared to IV administration. So jury's kind of still out on that. We'll see that as time goes on with the utilization of these in induction and inducing in UC as well as Crohn's as well as maintenance. So, that TBD to be determined in the future as we go along.
I think that's super interesting because we obviously dose things a little bit differently for just the arthritis piece to it. So I think it's really important for our listeners to understand that, hey, if they also have concomitant IBD, we really need to be working closely with our GI colleagues so that they're able to get those induction doses, because we don't really do that as much, in from the arthritis perspective. And you certainly would not want, oh, great, their joints are better, but now their gut is still flaring because we didn't dose it correctly from the beginning. And so again, just kind of really important that we remember to talk to our GI colleagues. And I'm interested to hear, how do patient lifestyle factors like preferences or potentially comorbidities influence the decision to initiate or possibly maintain subcutaneous therapy?
Yeah, I think those are all extremely important factors, really key factors that are involved in this shared decision-making, approach that we have with our patients, all of the above, really in determining that route of administration, both for the induction and the maintenance. You have considerations that include the simple ability to get into an infusion center, like I mentioned, living far away, busy schedules, allowing for patients to take a few hours out of their workday to come in for an infusion. We have issues with last-minute cancellations that then put that patient out of that window, and then we need to try to get them rescheduled quickly. How many times do you and I have these patients? Again, I mentioned living in the mountains. We get that big snowstorm, and they can't get down into the infusion center. Whereas a SubQ option wouldn't require that. We certainly talked about this earlier, issues with cost around infusion centers. And then we do have these younger individuals that we see, especially in the realm of inflammatory bowel disease. These little gals and guys are away at college, and so it's not as convenient for them. And older individuals, actually, those with comorbidities that are limited in their mobility, and it makes it less convenient to get into the clinic for an infusion. On the flip side, though, on the other side, I do have individuals who actually prefer to come into a center. They want to have that drug administered and they want to be monitored. There's issues with dexterity that maybe limit patients' ability to self-inject. Some patients have needle phobia, even with the option of the pen where they won't see that needle, or those that have injection site pain. So it really is a conversation that we have with each and every individual patient. And also just educating them, making sure they're aware of all the considerations, especially those that they're coming in with a new diagnosis of IBD. Clearly, it's new to them and they don't necessarily know what they don't know. So as a provider, it's really important to educate our patients, help them understand the different considerations with treatment options so they can really make that informed decision that works best for them and their lifestyle.
Given the overlap of our patient populations, I mean, you and I are fortunate because we can just text each other and say, hey, I have this patient, or if I have somebody that moves down to Denver, or, again, for me personally, it's about who the provider is. And so if I have to send a patient down, they are willing to do it. I'm willing to do it. If as long as I know the person and I know that the care is going to be really good, and I have no problems picking up the phone and calling anybody and saying, can you please see this patient? But how do you feel like rheumatology and GI providers can better coordinate care when managing patients with both the joint and the gut inflammation?
Absolutely. And I think this is one of the beautiful things that has come of GAP and RhAPP, and this ability to have these alliances as advanced practice providers across specialties, and just be able to have one another's contacts in our phone. It's been so incredible to be able to network both regionally and nationally. As you mentioned, when somebody's moving out of state, I know that there's a provider there in GI who might have connections with rheumatology as well. So we end up creating this network, not just within our own region, but nationally, which is fantastic. We do recognize there's a benefit from this multidisciplinary team approach for these patients that have these multi-organ involvement. But in the absence of being able to have these combined clinics, really the mecca, if you will, in vast majority of cases where we have both specialists who are able to have a shared visit with the patient, that's just not, realistic. Having the ability to just directly contact one another in a quick and efficient manner is really key. And I'll often share, again, my direct cell phone number with other providers so we can potentially communicate in real time. I can even step out of the office with my patient in some cases, and by a quick text or a phone call, I can get a response. I know what I know, and I know what I don't know. And when it comes to extraintestinal manifestations of IBD in the derm and rheum world, I really need to rely heavily on my rheumatology and dermatology partners to help me navigate that. I don't know what this little carbuncle rash that I'm looking at, is this important or not? Is this joint ache important or not? Is this something that I need to pay attention to? Absolutely. Do I know what I'm dealing with? No. And so I can quickly dial up Amanda and say, what am I looking at here? How do we manage this patient best? And as we build those strong relationships, we can really rely on one another for those quick referrals, getting patients worked in when we need to, and most importantly, just collaborating on those treatments that we feel will hit both diseases when necessary.
Yeah, I think, again, the key is really to just find your community, find the people in your community so that you're able to make those connections. And I mean, I have picked up the phone and called an office where I didn't know anybody and said, can I talk to the nurse practitioner that works there or the PA that works there? Because I do think that, yeah, we really like talking to each other. And so that's, I think, why it works so well. And also the feeling is mutual. When they start talking about their diarrhea or their whatever gut complaint, I have no idea what that is.
Right.
And I'm very quick to say, I really think you should go see GI because I have no idea if that's something or if it's nothing,
Yeah, absolutely.
Now, what practical lessons have you learned in incorporating SubQ biologics into your own practice, like particularly around adherence, safety, monitoring, etc.?
Yeah, well, I think practical really is that keyword within this question for sure. Really, that shift to SubQ options, biologics, and treatment modalities really does enhance that patient convenience and their quality of life overall. It's fantastic to be able to offer this to our patients, but to be successful, we do need to make sure our patients are well educated around their disease, not only just the medication itself, but around their disease state. Again, I mentioned that earlier, this often is a new diagnosis. as well as their therapy, including the need for adherence and what to watch for as far as safety and efficacy. And as a practice, we do need to offer those initial and even ongoing trainings on self-injections. It seems simple to us as the medical professional, but can be very overwhelming to a patient that's new to this type of treatment. And encourage our patients to call with any concerns, any questions they have, or any side effects that they may be experiencing, including concerns around flare symptoms that they could be having. Because again, we're no longer bringing them into an infusion center and locking them in for a few hours at a time to get an update on their status, both how they're doing with their treatment, but how their disease is doing. So we don't want to lose that tracking, if you will, when we move over to these SubQ therapies and options. We want to maintain that. We need to still be getting baseline assessments on our patients and periodic monitoring during their treatment. And while these agents have significantly improved in their safety profile, we certainly still need to be educating our patients on potential adverse events and provide a direct number for them to be able to reach out to with any concerns at any time. And finally, with the shift to more autonomy on our patient as a practice, as I mentioned, we need to put into place some level of accountability with periodic check-ins with them to make sure they're being compliant, staying compliant and adherent, and that they're remaining stable.
I think it's also, I utilize a lot of like the industry resources for the patients too, especially when I'm starting a therapy. So I would encourage all of our listeners, if you're starting a new SubQ therapy for, X disease, tell the patient to go to the website and like call the number, because there's so many good resources. Even just the hand holding piece of it when, this is scary for them. Like they're starting a brand new medication. Sometimes this is their first biologic and they don't know what to expect. That's frightening. And so to have additional people there that can support the patient, I think also kind of helps with that adherence piece to it and just puts their mind at ease. So I definitely, utilize those resources.
I think that's a good point to bring up too, because a lot of these therapies do come with the ability to link a patient with a nurse educator, an advocate, and somebody that can kind of be helping to keep that patient accountable when we're prescribing them through these specialty pharmacies, or if industry has recommendations around how to streamline the pre-authorization process. A lot of times they have these options available and opportunities available for patients to have this education, take the burden off our practice, our medical assistants, us as providers, and they're able to have these people in place that can be contacting our patient, make sure they're getting drug, make sure they don't have any questions, make sure they feel comfortable with their injections, and be able to be that support through the treatment itself, through that industry and where that treatment is coming from. They have these options. So that's a really good piece to bring up as well.
So I want to kind of close us out here, and I'd love to have your opinion on kind of what key takeaway would you like rheumatology providers to remember specifically about, since we've been talking about the role of subcutaneous therapies and IBD and their relevance to immune-mediated disease care overall.
Yeah, I think really that key takeaway for my rheumatology partners is that these SubQ therapies for IBD really do offer comparable efficacy to IV biologics in a safe and convenient form for our patients, and significantly reduce that healthcare burden. Given the shared pathway that we have across rheumatologic diseases, these treatments really can offer a broader management for these immune-mediated diseases and the crossover therein. So we can more easily call on one another, call each other up, and take a look in our shared toolbox at how to best manage our patients that have these, coexisting immune-mediated diseases. I think it's fantastic, a resource when we're dealing with these crossovers. So again, a comparable efficacy to the IV biologics, convenience, safety, and a shared approach that we can do with one another to manage our patients best.
This is super helpful to me because I think I had this impression. I don't know that, patients with IBD had to somewhat be on IV therapies. And, I realize I obviously see them when they're not, but it's super helpful to just have the conversation that no, actually, this is really convenient for the patient and works just as well in a lot of cases.
Yeah, I think in the past, we had very much predominant, especially for that more moderate to severe patient, IV infusions, and maybe our SubQ options, over a decade plus ago, maybe we didn't find as efficacious and we didn't have as much that had a crossover effect. But what we're seeing with all these newer therapies and newer agents that now also have SubQ, in a large amount for at least maintenance, and then one in particular that has for induction and maintenance, we do recognize that they're also very, very efficacious and very safe and well tolerated. So much gain across the IBD landscape in the treatment options that we have for IBD. But guess what? We also have these in the rheum and derm space as well. So yeah, I think that's something that's just fantastic to be aware of, and that we can come together even better, as I mentioned, with that shared toolbox now.
Well, it's just so important as rheumatology providers that we just remember that this is really a domain-based approach when we're coming up with a treatment plan. So, asking your patients that you just diagnosed with psoriatic arthritis or ankylosing spondylitis, or you see them for uveitis or what have you, that you have to ask about the gut, you have to ask about the skin, because there's often overlap, and this can change what your treatment is for that patient so that you're able to treat as many manifestations as you can. And again, just so incredible. I mean, both of us have been practicing around the same amount of time. And so to see all of these therapies get covered, come to market is just so amazing for our patients, and is why it truly makes it so special to practice every single day and watch patients just globally get better and live normal lives.
Yeah.
We don't see people coming in wheelchairs anymore, which is just so incredible.
Yeah.
With that wraps up today's episode of RhAPPcast. A huge thank you to Christina Hanson for joining us and sharing her expertise from a GI perspective. As we've discussed, understanding the evolving treatment landscape in Crohn's disease and ulcerative colitis isn't just important for our GI colleagues. It's critical for rheumatology providers managing patients whose disease extends beyond the joints. Subcutaneous biologic therapies continue to bridge the gap between specialties, making coordinated care and patient-centered decision-making more achievable than ever. If you enjoyed this conversation, please be sure to subscribe to RhAPPcast and explore more cross-specialty discussions designed to elevate your practice. You can also find additional educational resources and upcoming programs at rhapp.org. I'm Amanda Mixon. Thank you for listening, and we will see you next time on RhAPPcast.